بسم الله الرحمن الرحيم. آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير. لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت. ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملت على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين. صدق الله العظيم. تفضل يا كريم الدين.
طيب.
تفضل يا كريم الدين.
بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. It is my great pleasure and honor and privilege to introduce Dr. Tarig Muhammad Osman, a highly accomplished and distinguished consultant pediatrician with an extensive career spanning clinical excellence, medical education, and international practice. Dr. Osman obtained his MBBS and MD in an esteemed institute, University of Khartoum, 1986 and 1995-94 respectively. Then he achieved an international degree from Arab Board and Royal College of Pediatricians. And he was certified as a clinical teacher. And he achieved a lot of award and prize of excellence.
كريم معلش لحظة بس، لو عندك تو ديفايسز عندك تو ديفايسز يا كريم، just mute one of them please.
نعم.
If you have two devices, mute one of them please.
ممتاز جدا. Hello?
Ayo, go ahead.
Hello? You hear me?
Yes, go ahead ya Karim.
Dr. Osman, in addition, he had a postgraduate certificate in teaching and learning in clinical practice from University of Liverpool, reflecting his strong commitment to medical education and professional development. He was also awarded a certificate of eligibility for specialized registration in the United Kingdom. Dr. Osman's professional journey reflects a wealth of international expertise. He is currently serving as a consultant general pediatrician in Elder Hay, Children NHS Foundation Trust, Liverpool, United Kingdom, one of the leading pediatric centers in Europe. He also spent a good time as a general pediatrician in Qatar and in King Fahd Medical City in Kingdom of Saudi Arabia, where he was achieved a lot of prize of excellence. Dr. Tarig is a highly respected consultant pediatrician whose career is marked by both clinical excellence and admirable personal attributes. He is known for his deep vision, sound judgment, tolerance, and calm, which composed an approach to patient care and professional collaboration. This quality have significantly contributed to his reputation as a trusted leader in pediatrics and medical education. Really, it is my privilege to introduce him today. And at this juncture, may I invite Dr. Tarig to start his talk. Welcome, Dr. Tarig, and microphone is for you now.
Thank you, Karim, and thank you for the attendees for your attendance. Actually, I I received invitation to speak to you today, as I already told one of the panel on Wednesday. So exactly like 72 hours ago, I was invited to present. So this presentation, obviously, I just made some refinement to an old presentation that I have presented to my audience here in the UK. Dr. Karim is an old friend. Obviously, I think we are from the same group, دفعة يعني. We met quite early because I visited Juba when he was studying his medicine. I visited Juba as a medical student even before graduation. And as things evolve in Sudan, they come and completed their education, the university in with us in Khartoum. So we met again when they joined us in Khartoum. So and then obviously we were together as intern house officers in Khartoum North, where we both worked with one of the great pediatricians of Sudan, Dr. Zain Karrar, and I owe a lot of my passion for pediatrics to Dr. Zain Karrar, who guided me in my earliest career. I have left Sudan quite early. I think it was 1994, after obtaining my few months only after obtaining my Master of Pediatric and Child Health. And since that time, I have been roaming the world. I worked in 3 continents, Europe, Asia, and obviously Africa, Sudan. And I was privileged to work in some of the great hospitals in the region, because in Saudi Arabia, I worked in the King Fahd Medical City, one of the flagships Ministry of Health Hospital in Saudi Arabia for 10 years. And it was quite admirable and memorable experience. And I worked also for 3 years in Doha, Qatar, in Sidra Medicine, which used to be Sidra Specialist and Research Center, which is a pediatric hospital only, or a pediatric and maternity hospital, actually. Yeah. And after my return to the UK, I also privileged to work at Alder Hay Children's Hospital, a leading pediatric hospital in the UK and in Europe, and one of the leading hospitals worldwide. But I owe all my earlier experience to my training in Sudan, which I feel that I am deeply indebted to. And when I was contacted to make this presentation, even with a short notice, I couldn't say no. I welcomed the idea, and I apologize that obviously because of the short notice, I had to present something that I have presented previously. And as an introduction, obviously, this presentation can be presented to pediatrician, general pediatrician, or working in emergency medicine, to emergency physician who deal with children, to general practitioners. And obviously, it's not aimed for the cardiologists, if there are any cardiologists in the group. And chest pain might look like an uncommon presentation in children, but because obviously I have been seeing children with chest pain either referred to us from their general practitioners or referred from emergency medicine physician in the UK practice. And also, if I put my hat as working in emergency medicine, especially during my Middle East career in Qatar and Saudi Arabia, we used to see children with chest pain. I'm not sure how important is chest pain from the colleagues who are still practicing in Sudan. But I am sure that either in your private practice in clinics or in your hospital practice in different settings, you will encounter children presenting with chest pain. And as you will see also, the epidemiology could be different, and the causes that is meant here, because most of the studies I am going to refer to are done in the Western world, in the US and in Europe. They might not be a mention for rheumatic heart disease, which is still a major cause for cardiac disease, morbidity, and mortality in Sudan. Okay, so the objective of this talk is obviously to evaluate and distinguish between benign and serious causes of chest pain. Obviously, luckily in children, the most common causes are usually benign, but obviously what comes to people's mind, parents and also to physicians, and is they think about heart disease as a major cause of chest pain in children, because the adult experience. In adult practice, it's a different game altogether, because obviously in adult practice, they got their protocols and it is cardiac until proven otherwise, while in children, it's not cardiac until proven otherwise. I will describe an approach to pediatric chest pain that is very simple and will reduce the need for a necessary test. And this reminds me with obviously when I worked in Saudi Arabia, we used to have some colleagues who are trained in the US. And we find that the colleagues with US training are more risk evaders, and they use a lot of investigation. So I don't remember how many times I asked for troponin to rule out myocardial ischemia, but some people in their routine practice, chest pain means we do a full battery of investigation. Obviously, this might not be readily or available in many places, especially in Sudan. And you will see as well that it's not really needed in most of the cases. It's very small percentage that you might think about myocardial ischemia as the cause or cardiac cause for chest pain, and you need to do more elaborate investigation. Okay, so obviously, common complaint you may argue about this, but we think that it's a common complaint in our population of patients, because for many reasons, because we have here a big number of adolescent population who can present with chest pain because of the anxiety or mental health issues, or because of other factors like drug abuse and so on, as we will see. And as I already said, that the majority of the cases are usually benign, and you will see obviously through the presentation that a good history and physical examination can determine the etiology in most cases. And testing is not necessary except in the very small minority of patients. I think the importance of chest pain comes from the link to heart disease. So the common etiologies, obviously, chest wall pain or musculoskeletal pain. Respiratory causes are probably next, and these can be pleuritic pain, pneumonia, and causes gastrointestinal pain, that is gastroesophageal reflux disease and gastric pain can present as a chest pain, obviously. And the old wisdom that abdominal pain in adult think about chest pain, and chest pain in children think about an abdominal cause. We touch about psychogenic and cardiac. And so I'm going to touch about some studies. You may notice that some of them are relatively old, because the presentation also is like 2-3 years old. or maybe more than that. Time is running fast. So there is a cohort study just looking into the causes of chest pain and how much of that can be due to a cardiac cause. There is a study done that looked into two groups of children who are over 5 years, looked into those who presented to the pediatric emergency department. And usually we assume that if somebody presented to emergency department, this is more acute form of pain, or at least the level of anxiety and worry was rather high in the parent of this child, so that they couldn't wait to go to a general practitioner to be referred to clinic. And the other group is children presenting to pediatrics clinic referred by GB, and these were referred to a cardiology clinic. So obviously the numbers almost more than 2.5 in the first group. But they found that those who presented to the emergency department, the chest wall causes of musculoskeletal pain was more than 2/3 or almost 2/3. And those who presented to the clinic setting, which is less acute setting, it's even higher, almost 90% were chest wall pain. And there is another study looking at the same issue, what is the percentage of heart disease in children presenting on chest pain. This is a retrospective medical record review in University of Wisconsin Medical Center. And out of 135 children presented with chest pain during the study period 2004 to 2006, they found only one child had a cardiac cause. So that's less than 1%, 0.7% had a cardiac cause. Similarly, another study of 161 children, only one patient has a cardiac cause. This is just to highlight that the cardiac cause for chest pain in children is very, very rare and very small. And obviously, this is quite obvious to all of you. Doesn't probably need to be very much highlighted in these studies, and this will highlight the importance of history, physical examination are the main prime factor to reassure patient and rule out serious cause. And this will be the role of the primary physician and to avoid a lot of investigation. There is another study, a larger one in two pediatric emergency department, large tertiary center department. They looked into 4,000 and almost 4,300 children visits. When we say visit, it could be the same child presenting more than once, but they look at each visit as a separate one. And it took about 3.5 years, and this just indicates, although these are two large centers that may see over 100,000 visits in a year, chest pain could not be a very high prevalence or very high incidence to this tertiary emergency department. All these children, they excluded any child with a history of cardiovascular disease. So those who are known to have previous heart disease, cardiac surgery, and others are excluded. So from the nearly 4,300, only 24 children, that is 0.6, had a cardiac etiology during this period. So again, it is saying similarly that less than 1% of the children have cardiac disease. And the breakdown of these 24 children, that 9 of them had arrhythmias, 6 of them had pericarditis, 4 of them had myocarditis, 3 of them had acute MI, which may come as a surprise because we will see that there are obviously causes for myocardial ischemia in children. It could be congenital, it could be something acquired. And one of them has a pulmonary embolus. Pulmonary embolism is a rare cause of chest pain in pediatrics. But the majority, almost all of them, except 1% or less than 1%, has a musculoskeletal or chest wall disease or the other causes. So the majority, more than half of them, musculoskeletal cause. Respiratory causes are 12%, infection 8%, gastrointestinal causes 6%. Sickle cell disease is 4%. And again, this may differ in our population. For example, if we come to areas where there is prevalent sickle cell disease in the population, the percentage is likely to be higher. It might present as a chest pain. This is, or it can be present as acute painful crisis or others. And as I mentioned, there is no mention here in the cardiac cause or rheumatic heart disease as a cause. So the risk factor for ischemia could be congenital heart disease, especially if somebody has repair of transposition of the coronary arteries that might lead to some stenosis at the ostia of the transplanted coronary arteries. Familial hypercholesterolemia is very rare cause of obviously ischemic heart disease and coronary artery disease. Kawasaki disease, we see it in pediatrics, acquired disease, obviously, not very uncommon, but it can cause obviously myocardial ischemia due to coronary arthritis. And we always think about coronary arthritis as the most serious complication of Kawasaki disease. And I'm sure that all of us in our practice from time to time, you see Kawasaki disease, whether it fulfills all the criteria or if it's atypical, but you keep them under surveillance for ischemic heart disease and coronary arthritis. A very rare form of congenital heart disease is ALCAVA, which is anomalous origin of the left coronary artery from the pulmonary artery. Actually, in my long practice, I've seen only 2 cases, and probably you need to be working in a center with a cardiac center to get to see one of these, usually presenting during infancy or very early childhood. And they will present with a typical feature of myocardial infarction because obviously the coronaries usually fills during diastole, and if they are coming from the pulmonary artery, they will cause ischemia, and they present with typical chest pain. Obviously, in a small child, that an infant that will be crying, sweating, and you don't know exactly from where the pain is coming, what is causing the crying, and sometimes gone missing for some time until complication of heart failure appears due to failing heart muscles, and then as part of the investigation of the heart failure, an echocardiogram or ECG shows evidence of myocardial ischemia, and then further investigation with angiogram shows anomalous origin of the coronary artery disease. So it is an important, when we find it, usually it will be like a case presentation and an important cause, but it's not, it's very, very rare. And sometimes, obviously, in setting where there is limitation of investigation, might go unnoticed and might be misdiagnosed or might not be diagnosed at all. We spoke about sickle cell anemia, and spontaneous coronary artery dissection is a very even rarer condition. I've not seen one. And this is what I meant in our practice. Drugs can be a cause of ischemia, especially this is now adolescent in Western countries where there is sometimes high prevalence of drug use, especially cocaine or amphetamines. And unfortunately, I think this issue of drug use is now expanding to the Middle East and even to Sudan. We all, I think, hear about the wide prevalence of drugs, ice and some new other drugs that can obviously lead, or ketamine now is quite common, the ketamine drug misuse in adolescents that can lead to this. So an adolescent child who you might think about that as a cause of myocardial ischemia. The presentation will present few clinical scenarios, I think about 4 or 5 clinical scenarios, and I want you to participate. Obviously, when I presented this, to a face-to-face group, I usually ask and wait for the response from the group, and that make it an interactive presentation, because if I just kept speaking, you probably will get bored or fall asleep. So still here, I think you can participate, and I think the panel will, or Dr. Taha and his colleagues will help me with your answers to the questions. So this is our first scenario, that a 12-year-old healthy male presented with 1 hour history of sharp left-sided chest pain worsening with deep breaths. What history do you want to know?
So the floor open for the attendee if you want to interact.
Obviously, I will not wait for long, because the presentation time is limited, and I got a long presentation. I hope to finish on time. So if you don't volunteer the answer, just think about what other history
So
that you
there's
want to
some
know.
answers here. Dr. Tarig,
Yes,
ask about severity of pain, cough,
yes,
fever,
yes,
and someone any recent flu-like symptoms,
yeah. Okay, so that's
history of
this.
trauma. Yeah.
Yeah. So this is, yeah. So you ask about, is it exertion related to exertion, whether there is any palpitation, whether there is any fainting episode or syncope, whether there is sweating, whether obviously things like the sweating can be a sign of heart failure and so on, whether there is orthopnea, dyspnea, dizziness, fatigue, and fever. Fever is quite important one, because it may point to something. So in our patient, there is no relation to exertion, and there is no fever or other constitutional symptoms. And the past medical history is not significant. There is no past medical history of any heart disease or any other illnesses. And also there is no significant family history. So then you come to evaluate the patient. After you took the history, you will examine the patient. So you will, obviously, especially for people who work in the emergency department, the vital signs is very important. So especially to evaluate the cardiorespiratory function and stability. So you'll check the blood pressure, heart rate, respiratory rate, and temperature. You will look at the work of breathing, and you will look also listen to murmurs, pericardial rub, galoprism, diminished heart sounds, because these are all indicator of different cardiac problems. Hepatomegaly indicating heart failure, decreased peripheral pulses, always indicating heart failure, or obstructive left heart lesion, peripheral edema, marconoid features, and this is more specific to chest pain. If somebody presented with chest pain, palpate the chest. So press over the costochondral junctions and see if there is any tenderness on pressure over the costochondral junction, and if this pressure is reproducible. It is localized, and you can reproduce it every time you make the pressure. The position or posture of the patient could be also important, because some condition may get aggravated if they lie down, so patients tend to be sitting or leaning forward or so on. So these are the physical examinations that you needed. So this our patient is slightly anxious appearing because of the chest pain. His blood pressure is 136/80. His heart rate is 118. His respiratory rate is 24. His temperature was 36. His oxygen saturation was 100%. I put obviously the abnormals in red. So he's having a slight increase in systolic blood pressure, and he was a bit tachycardic. Examination of the chest, no normal chest. Examination of the heart is again normal, no measurements, no pericardial rub. And there is tenderness at the left sternal border on palpation of the chest. So what is your diagnosis? And the second question, do you need to do anything else after this? Any volunteers and answers?
Give it a minute just for people to respond. There's one comment here that they would like to ask about the child family and school relationship referring to the child age.
Okay. Yeah, but
answers. Yeah, sorry.
Yeah, go ahead. Yeah.
So answers costochondritis, muscular, and treatment analgesia. Someone stated ECG, but most answers are costochondritis.
Yeah.
Multiple people.
Okay. Yeah, so that's well done. Yeah, well done, because this is a classical case of costochondritis. And as we see, and as I think it's reasonable that you do an ECG in any child with a chest pain. ECG is a very simple test. It's non-invasive. It must be readily available in any hospital or clinic setting. And it is a very cheap investigation, shouldn't really cost more. So what do you see from this ECG when you did the ECG? Yeah, as you can see. Yeah, obviously there is only sinus tachycardia from this ECG, and you can count the heart rate by dividing the number of large squares by 300. And it is, as we mentioned in the vital sign, is around 110, 120 heart rate, 118. So back to the case, the salient feature is an anxious teenager, systolic elevation of the blood pressure, tachycardia, reproducible chest pain, and the diagnosis is costochondritis, as you mentioned. Because when we say musculoskeletal pain is a general term that can include, obviously, commonly could be costochondritis. And costochondritis is a frequent cause of chest pain. It's not related to trauma. So one of the questions that we haven't asked, what we should ask, is if there is history of trauma, because trauma can lead to rib fracture, can lead to muscle contusion, can lead to lung contusion, and all this can cause pain. It's usually costochondritis is unilateral. It doesn't affect both sides, and usually very localized to the left side and specifically to the fourth sternocostal junction. And you can get the diagnosis from history and physical examination alone. And if you have to do anything, probably you just do an ECG. And it will not show anything more than the sinus tachycardia. And as mentioned by one of you, that the treatment is rest, reassurance, and analgesia. Obviously, anyone presenting with chest pain in this will be thinking about heart disease, but you don't need to proceed for any further investigation. You do not need to refer them to cardiologist or for cardiac assessment. No need for echoes, no need for anything, and you can just reassure. And it is quite common, as we've seen, this maybe 50% of the cases presenting with chest pain could be that. And the clues are that it's the sharp pain, it's usually left-sided, it wears with inspiration. So things that get worse with inspiration, not only pleurisy or pleuritic pain, but again, chest wall pain can be, because the movement of the chest with respiration can lead to the aggravation of the pain. And the most important physical sign is a reproducible costochondral junction pain with normal rest of examination. So there is no other abnormality detected on examination. So the musculoskeletal causes of chest pain, costochondritis is number one. Other causes, sleeping grip syndrome, precordial catch syndrome, muscle pain, chest wall contusion, rib fractures, and malignancy. Another clinical case, 6-year-old male with intermittent, sharp, stabbing, left-sided chest pain, duration from seconds up to 5 minutes, with complete resolution. Just look at this, that it comes and go, and in between, it resolves completely. During pain, the child is very upset and crying. Obviously, he's a 6-year-old, so he might get very upset with that. This is his vital signs and physical exam. Blood pressure 96/60, heart rate 100, respiratory rate 20, saturation 100%, temperature 37 degrees. So normal vital signs. He was happy and smiling because you saw him after the pain settles. The pain comes and goes, and it was very short pain. It's only few minutes. The chest was clear, and the cardiac examination, no pain on chest wall palpation, so it's not costochondritis, and no murmur, no pericardial rupture, basically normal examination. So what is the diagnosis here?
Somebody saying it's probably muscle spasm. Other answer maybe GIT in origin, muscular pain.
Yeah. Okay, so
reflux.
this is, yeah, obviously all these are fine. You can also say that it is a chest wall pain as a general term or so, but there is a specific condition that I want to highlight. It is called, obviously, it got three names. It's a benign paroxysmal chest pain, and this is a descriptive term, obviously, because it's benign and it comes and goes, and it's a chest pain. The other two names, I don't know whether you have heard of this, Textor twinge syndrome or precordial catch syndrome. So this is a benign condition. It's localized to an intercostal space, usually in the left side or at the apex, and comes at rest and or with mild activity. So there is no exertion. The pain does not get aggravated with activity or exercise or exertion. The cause is unknown, although it is thought that it's either due to entrapment of one of the subcostal nerves or due to irritation of the pleura, the pleuritic irritation. Not exactly known what's that, but sometimes also it's related to certain position. And it is a diagnosis of exclusion. So if you cannot find any abnormality and you want to exclude other causes, this will probably be the precordial catch syndrome. And it's quite common. And one of the things that it is very, very brief, very sharp, and it comes and goes, and in between the child is well.
Tarig, somebody is asking how common is this diagnosis?
I think probably it is fairly common in an uncommon condition, which is chest pain in children in general. So I think the hallmark here, because our aim is if a child presented with these features, that he's having this chest pain that comes and goes and is very brief and is not associated with any findings of respiratory distress, not related to exertion, the findings are always normal. You find normal heart rate, normal blood pressure, normal respiratory rate, normal saturation, normal cardiac auscultation, normal clinical examination in general, then you can confidently diagnose it as this one. Because as you will see that all the cardiac causes will come with abnormalities on vital signs or on clinical examination. So if that you probably, I think if you are going to do anything, you do an ECG, also it 100% will come normal because even the heart rate is normal. So a normal ECG might be more of a reassurance to parents that you have done something, because I use in my practice obviously to reassure parents as well and to do simple things, to do ECG for chest pain. And sometimes for a limited number of patients, you can do also chest X-ray because it can tell you about the shape of the heart, the size of the heart, the shape of the lungs. You can rule out pulmonary causes and so on. So chest X-ray and ECG are two simple investigations that you might do, and it will help you to rule out maybe 90% of other causes. So just think about it, this precordial catch syndrome. It's not a common diagnosis that you find it in books. I'm not sure, did it come, has anyone not heard of it before? If not, then this will be one of the things that this presentation will add to your knowledge.
What is the treatment somebody is asking, apart from painkillers? Is there anything else?
No, just reassurance. You don't need to do anything. And it is usually remitting, self-resolving, and usually disappear after as the child grows. It's common between 6 and 12 years of age and usually disappears after that. I think, yeah, it might be some stimulation to go and read about precordial catch syndrome or benign paroxysmal chest pain. Okay, so another case, clinical case, just to go. I don't want to exceed time because obviously I'm already less than half in the presentation and more than half of the time. A 14-year-old obese male with chest pain associated with shortness of breath over the past 2 days, low-grade fever, recent ankle injury. Okay, these are the vital signs. Obviously, systolic hypertension, tachypnea, tachycardia, tachypnea, and fever. Clear chest, no murmurs, no reproducibility of the pain, right ankle in a splint. Any ideas? What is your diagnosis?
PE, people are talking about PE, possibility of PE.
Yeah, PE is a very good suggestion because obviously I think the two important things that you got an abnormal findings, vital signs, there is tachycardia, tachypnea, hypertension, and fever. And this is or probably the clue for PE that you got right ankle in a splint. Okay, so PE is pulmonary embolism is a very rare cause of chest pain in children, but still it does occur. And the risk factor for PE is similar to risk factor in adults, but you probably include the nephrotic syndrome, which is more a childhood disease, nephrotic syndrome. But we mentioned this is an obese child, so obesity, and especially it is now a growing problem worldwide that we find a lot of obese children. But a history of recent surgery, history of trauma, history of central venous catheter or TPN. You need a central venous catheter probably to start TPN. History of malignancy, infection. And this is an important one in probably on more in Western world. I think still we are a very conservative community. I don't think our adolescent girls will be taking birth control pills. So these contraceptive pills can increase your risk for PE. And it's very common, obviously, in the West that we see it. We see, I mean, children with taking, adolescent girl taking contraceptive pills, not PE. We don't see PE common, but you need to think about it because you've got a high population that is taking contraceptive pills. So pulmonary embolism is rare in childhood, but the evidence suggests that it's under-recognized. Children diagnosed with PE at a large tertiary center over an 8-year period were respectively reviewed. 56% with radiologically proven PE were identified. So we got 56 patients from this 8-year longitudinal study. 31 of them are boys, so more boys and girls, which you expect probably in adults, the reverse, 25%, 25 are females. Their median age is 12 years, so mostly early adolescence. From the 56 children, 96% had a risk factor. Immobility for one reason or another, whether they have like this one, a splint or fracture or something like that. That's in about 60% of them. Central venous axis in about a third, 35%. Recent surgery in just over a quarter. And obviously investigation done because if you find PE, you will need to investigate further what is the risk factor for this PE, why it happened. Thrombophilic abnormality was found in about a third of the patient and concurrent deep vein thrombosis in 31 patient. That is just over half. And if you suspect it, obviously you do D-dimer, and that was done in 30% of the cases, and it was elevated in 86% of them. So 26 out of the 30 has an elevated D-dimer, and usually in PE, the D-dimer is sky high, it's very high. So it was more than 5 times the upper limit in the majority of them. The
Someone is
symptoms,
saying, could it be, could you say it's more common in obese children? Of course, yeah.
yeah, it is. Yeah, I've already mentioned that is in the previous slide. Shortness of breath, pleuritic chest pain, hypoxemia, acute cardiovascular collapse can happen in about 7%. They may present with cardiac arrest. Additional signs, especially if it is a massive embolism, and additional signs include persistent unexplained tachycardia and fever. 16 patients, that is just over a quarter of them, had symptoms of deep venous thrombosis at presentation. Obviously, the management could be anticoagulation, thrombolysis, inferior vena cava filters. Okay, and the outcome, the majority, over 80%, complete or partial resolution when followed up at 3 months of time, and recurrent thromboembolic event happens in 7 patients. That is about maybe 10% or so. And there is high mortality. That is what was striking in this group of patients that's followed up. 12 patients died. That make a mortality of over 20%, which is a high mortality. 5 of them died because of thromboembolism. The process itself was a massive emboli or cerebrovascular accidents or so on from the emboli shooting to the heart. 2 of them actually died of hemorrhage, and usually the hemorrhage due to treatment. So your thrombolysis and anticoagulation led to brain hemorrhage or so on that caused the death. So this is more of a collateral damage or iatrogenic cause of death in this group of children. Risk factors could be distinct in children from adults, especially as we mentioned, the nephrotic syndrome, and the mortality is quite significant. Evaluation, you will do a chest X-ray, ECG, D-dimer. You may do VQ scan or CT chest with contrast, cardiac and pulmonary angiogram, echocardiogram, venous Doppler, if you consider for deep veins DVT, deep veins thrombosis, and you work for hypercoagulable state. So the ECG in EE, the simple test, the ECG will show you sinus tachycardia. It may also show you non-specific ST wave changes. And in severe cases, it may show you right heart strain with S wave in lead 1, Q wave, T wave inversion in lead 3. Obviously, here are the changes in the ECG, the ST segment elevation. Immobility, central venous, I think we mentioned that already, recent surgery, and chest pain with shortness of breath, think about it. And D-dimer is a simple test that you can do it, and it is diagnostic if it's very high. Can myocardial infarction occur in children with non-anatomic abnormality presenting with chest pain? I think the answer is yes, and we will see. I will try to rush more because I think I'm running out of time, and I try to present all the presentation. Otherwise, I may cut it at the end if we run out of time. So myocardial infarction in healthy adolescents is another study. Clinical history, ECG, echocardiogram, cardiac enzyme levels were evaluated in patients presenting to emergency department at Akron Hospital over a period of 11 years. So you see, it was a long longitudinal study from 1995 to 2006. And the patients in whom they found evidence of myocardial infarction, they had the drug screening because, as we mentioned, in a group of adolescents, they may be drug abuser using cocaine or amphetamines or so. Serum lipid level, looking for familial hypercholesterolemia and hypercoagulability state workup, including thrombophilia screening. When myocardial infarction was diagnosed, they undergo cardiac catheterization and angiogram, coronary angiogram. They found 9 adolescents with acute MI all of them, they don't have any risk factor. They presented with typical cardiac physical clinical history and physical examination. Almost all of them, 8 of them, had signs on ECG, ST elevation or Q waves or S waves and so on. 9, all of them had abnormal cardiac enzyme, the CK, the muscle enzyme, and the troponin were elevated in almost all of them. And the echocardiogram features might be late findings, so only a third of them showed cardiac abnormalities on echo. The drug abuse, lipid profile, and hypercoagulability test were negative in all 9 patients. This is our ECG changes in myocardial ischemia, the ST elevation, the T wave inversion, and the Q waves. Again, in here, you can see the Q waves, deep Q waves, ST inversion, and T wave inversion. So from the Children's Hospital Boston and Harvard Medical School, they did a retrospective study of all patients between 7 to 21 years presenting to the cardiology outpatient department in 2009 with elevation for evaluation of chest pain. And they look into demographics and patient outcomes. And they found what investigation required is ECG in all of them, 406 patients, all of them had ECG done. Just less than a half had an echocardiogram done. Over a quarter had exercise stress test done. And 10% had event monitoring, that's a cardiac memo, and 7% had a Holter monitor. And from the 406, only 44, that is 11%, had a clinically significant medical or family history or abnormal cardiac examination or abnormal ECG. It's important here whether it is there is exertion with chest pain or not, and the presence of associated symptoms like syncope, palpitation, dyspnea is also taken into account to indicate more serious cause. So we've seen at the beginning the benign causes, costochondritis, or there will be no syncope, no palpitation, no dyspnea, almost normal findings, except sometimes tachycardia. But the presence of any of these might point to a more serious cause.
Somebody is saying, Dr. Tarig, sorry, we have seen a lot of PE cases post-dengue fever during the outbreak. And also, I think, did you see any change during the COVID time?
Yeah, actually, I spent most of the COVID time in my in Doha, or all the COVID. Actually, one of the reasons that I left Qatar is that I was locked down from my children in Doha for nearly 2 years. I couldn't move and so on. So after the COVID lockdown was lifted, I resigned and come back to the UK. So I've not seen in Doha this PE with COVID, but it's interesting. Obviously, I've not seen dengue, obviously, because of the area of practice, and it's quite interesting that my colleagues in Sudan, they have seen PE in following dengue fever, which is interesting. But because probably it can cause some hypercoagulable state or so on. I'm not sure. I have no experience to be honest with that. But it's a good information. So as you mentioned, systemic inflammatory condition like SLE or JRA, thrombophilia, myopathies, carnitine deficiency, malignancy, and congenital adrenal insufficiency. This can be, if you got a past medical history of this, can lead to this. And you can get a concerning family history if there is sudden or unexplained death, if there is history of cardiomyopathy in the family, hyperlipidemia, and pulmonary hypertension. Do you know these this man, anyone knows this football player?
Liverpool, ex-Liverpool player.
No, it's actually, this is a Brentford.
Tottenham.
This is Brentford shirt, but he also played for Manchester United. Yeah, obviously this is Christian
Eriksen.
Yeah, Christian Eriksen, because he nearly died during a football game in 2021. He was playing Euro. Obviously, he's from Denmark, so Denmark was playing Finland, and in the middle of the pitch, he's one of the very best midfield players worldwide, and he just fell. He had a very sudden, sharp chest pain and collapsed to the ground. He had a full cardiac arrest for 5 minutes. There was no cardiac output. He had full resuscitation done on the playground. He had cardioversion, defibrillation, and he survived. Was taken to ICU, and luckily he returned to play after that. Actually, following that, he joined Manchester United. This is him with a Manchester United shirt. 8 months after he collapsed at Football European Championship, he returned to play very high level football. So he's the first top flight player fitted with an implantable cardioverter defibrillator, ICD device, which can reset the heart after a cardiac arrest, because he got some form of rare arrhythmias that led to his, although he was absolutely healthy before that, he played to his national team when he was 18. So this is how a tiny device lead to this miraculous football return. So I said that is probably just to make people awake. This is a miraculous recovery from one form of chest pain that can be of cardiac origin. Concerning physical examination include galoprism, basalogic mema, pericardial, all these are cardiac causes, obviously heart failure and congenital heart disease, pericarditis, abnormal second heart sound, pulmonary hypertension, distant heart sounds, pericardial effusion, hepatomegaly heart failure, decreased femoral or peripheral pulses, obstructive left heart lesions, pericarditis, cardiac tamponade, all this can cause it. Peripheral edema, painful or swollen extremities, again, heart failure, tachypnea, and fever mainly in pericarditis and pulmonary embolism. Any abnormal ECG findings are significant, make you think about a serious cause, a cardiac cause specifically, ventricular hypertrophy, atrial enlargement, ST segment changes or T wave changes, high grade AV block, third degree heart block, or ventricular or atrial ectopy, and axis deviation, extreme right axis deviation or left axis deviation of any degree.
Dr. Tarig, one of the attendees is asking what is the significance of sinus bradycardia in preschool children presenting with chest pain?
Yeah, it can be just the pain itself that is causing the tachycardia. So I will not take it as a
Brady.
brady. Yeah, the brady, if it improves with exercise, with obviously, what is the level? If it is very low, then ECG look for heart block, whether second degree heart block or third degree heart block specifically. But if the ECG is only sinus, not there is no second or third degree heart block, and it's only sinus, and it improves with exercise, it might be just a very athletic child whose his heart rate is set at a lower level. I won't take any more notice of it. I will probably skip this because this is a standardized clinical assessment tool that is done from that study to evaluate the patient. So just for the sake of time, I will skip few slides looking at into this, and they try to prospectively evaluate the rules that they have made. They made a pediatric chest pain guideline using SCAM, which is a standardized clinical assessment and management plan, which is like a flow chart. And they said that with this flow chart, if they apply it to the group of the study, that will save some investigation. So they did a prospective study after that, and 2 patients had chest pain due to, they found only 2 patients had chest pain due to cardiac etiology, one with pericarditis, one with anomalous coronary artery origin. Testing performed outside of the guideline did not find anything specific. So this is a study that they looked into this, and a total of 1,016 patients were enrolled, and in Boston Children's Hospital and the New England Congenital Cardiology Association practice. They used the algorithm, which mainly history, physical examination, and ECG to categorize children, and to, according to this, if he's a low risk for any serious cause of chest pain, they will not do any further investigation. They do investigation only if there is abnormal findings on the physical examination, echocardiogram, or if there is the history also is pointing to a cardiac cause. And they, according to this, they saved a lot of investigation when they did this rule. This is another case, because I think probably case is more important than just this study. 5 years, female with fatigue, fever, and chest pain. Chest pain is sharp and consistent, centrally located, radiating to the left scapula, worsens with respiratory effort or lying flat. Recent upper respiratory tract symptoms. What do you think? This is a physical examination. So think about, from the history, what could be the possibilities, and look at the findings on the physical examination. Vitals, the blood pressure is a bit on the lower side, systolic 88, diastolic 58. There is tachycardia, so low blood pressure, high heart rate, normal respiratory rate, saturation, and fever. Chest wall non-tender to palpation. The pain increases when you lie flat. We see now is the answer here, I think. Friction rub on auscultation of the heart. Capillary fill time is less than 2 seconds. So this is obviously with a friction rub, this is a pericarditis.
You get myocarditis, acute pericarditis, someone is saying pleurisy, but lots of pericarditis and myocarditis.
Yeah, I think, pericarditis, myocarditis is quite a sensible thing. And obviously, when there is a friction rub, there is pericarditis high on the list. Obviously, sometimes if the effusion is high, you might not get the rub, but you will get these findings that he will be decompensating with hypotension, tachycardia, and so on. This is X-ray. What do you see on the X-ray of this patient? You see cardiomegaly, and do you see here as well? And pleural effusion. Bilateral pleural effusion. So cardiomegaly, bilateral pleural effusion. This is the ECG of this patient. What do you see on the ECG? Here, here, here. You see ST segment, elevation, peaked or tall T waves. So they look into pericarditis. So this patient has got pericarditis. Pericarditis study, retrospective chart review over 7 years, 94 patients, 22 of them had pericarditis, and they analyzed them. Mean age 12.3 years. Chest pain was the main symptoms, 96% of them. Almost all of them presented with chest pain. Just over half of them have fever. So fever is not a consistent feature in pericarditis. Pericardial rub was found only in 1 patient, which is a bit surprising that out of 22 patients, you find only 1 had a pericardial rub. ECG changes are present in all of them. So ECG is a very useful tool if you suspect pericarditis. Chest X-ray could be normal. In over a third of them, it was normal. And the rub is not as sensitive, obviously, as the echo. So when you do an echo, even if there is no pericardial rub, you find pericardial effusion in about 82%. The 22 patients, here is the time when you are suspecting pericarditis, there is fever, then you may do inflammatory markers because this is an inflammation. And they find increased white blood cell count, increased ESR, 61% had more than 30 millimeter. CRB, all of the one tested for CRB, they have elevated CRB, 22 patients out of the 22 patients. And troponin level was elevated in the majority of them, 86%. Pericarditis, obviously, commonly it could be viral, and hence the history of a preceding viral upper respiratory tract infection. It can be idiopathic, non-specific cause, can be tuberculosis, can be vaccine-related, can be related to inflammatory condition, connective tissue diseases, SLE, ulcerative colitis, systemic rheumatoid arthritis. The chest X-ray is shown in large hearts, that's, as we mentioned, in about 40%. ECG changes in all patients. It can show low voltage if there is large effusion. And you may find increased inflammatory markers, increased cardiac enzymes, and blood culture and viral cultures or serologies or PCR for DNA, viral DNA can be positive. And obviously, if you suspect pericarditis because of the pericardial effusion and cardiac tamponade risk and so on, you will need cardiology consultation. Okay, so one last case. I'm conscious that we are already over an hour, so I will just finish in the next 5 minutes or so. 16-year-old boy, previously healthy, presented to our hospital for acute onset sharp left-sided chest pain. Pain worsens with inspiration, presented as a tall and thin boy, looks anxious and slightly tachypneic. Rest of the vital signs were normal. On physical examination, he has diminished breath sounds, hyperresonant percussion, and decreased vocal fremitus on the affected side. So what are these history and findings telling you?
One answer, pneumothorax.
Yeah,
Lots of answers. Yeah, pneumothorax. Yeah.
Pneumothorax, yeah. So this is pneumothorax, and it is a cause of chest pain. It's a cause of a respiratory cause of chest pain. So pneumothorax was managed conservatively with resolution. 4 months later, he had a recurrence of left-sided pneumothorax, and 1 week after that, he presented with a contralateral pneumothorax. So he's having recurrence of the pneumothorax. He underwent video-assisted thoracoscopic surgery twice for polyectomy and pleurodesis. No further recurrence was stated. Additional investigation showed a prolapsed cardiac mitral valve. Marfan syndrome was suspected, obviously, and was confirmed by genetic testing. And this is a patient. Obviously, he got a Marfanoid habitus, quite long. Obviously, you'll find that the extremities span is higher than his height. He got the positive wrist signs, and also he got a positive thumb sign. So spontaneous pneumothorax typically occurs in older male adolescent and is associated with a tall, thin body habitus. Other important underlying causes include drug use. Also can lead to pneumothorax if you are using cocaine or amphetamines. Scuba diving, airway disease, in asthma or cystic fibrosis, congenital lung disease, especially this is in infants and toddlers when they have got congenital lobar emphysema, cystic adenoid malformation, sequestrated lung, and so on. These are congenital lung conditions. Foreign body aspiration, again, this is left and not treated, and so may lead to pneumothorax. A rare cause that I have never seen, menstruation in post-mechanical, menarcheal females, and connective tissue diseases like Marfan syndrome or Ehlers-Danlos syndrome. So the summary of this presentation, the take-home medicine, that it is a common symptoms. I assume that it's as common in your practice as it is in our practice. And it's typically benign etiology. Musculoskeletal etiology is the commonest, with if there is normal examination, no risk factor, no further investigation are needed. So if we got this message through, that's what we need. If you are going to do any investigations, then do an ECG, probably sometimes chest X-ray. Labs are rarely needed if it's not costochondritis, not reproducible pain. If there is abnormal examination, if there is concern for a cardiac etiology, because there is palpitation, dyspnea, syncope, or fever, and do this investigation, more investigation. And if you are suspicious of pericarditis, myocarditis, arrhythmia, or syncope, then cardiac consultation. Thank you.
شكرا جزيلا.
Yeah,
Okay.
this is the end of my presentation. Yeah.
Dr. Taha, is there any question?
Yes, there are a few questions. Thank you very much, Dr. Tarig. I would like to welcome Professor Sati as well. He's in the panel. First question, Dr. Tarig, Dr. Hanan, is aortic stenosis the cause of pain in adolescents?
Yeah, it can cause chest pain, and obviously depending on the
Severity.
Severity of the stenosis.
Dr. Abdullah is asking, what are the indications to go for 24-hour ECG?
Yeah, 24-hour ECG and cardiac memo, which is are indicated if palpitation is a prominent feature with the chest pain. Obviously, if you are thinking of arrhythmia as a cause of the chest pain.
How can we diagnose pericardial effusion by chest X-ray? Is it just another question?
It's not a very sensitive one, as we've seen from the studies that presented with pericarditis. 40% has cardiomegaly on chest X-ray. So if you suspect it, a normal X-ray does not rule out pericarditis. So again, if the child has chest pain, has typical chest pain with pericarditis that is posture related, that they want to lying down makes it worse, they lean forward or they sit up, and if you hear a pericardial rub, or if there are fever or tachypnea, and you suspect that, obviously echo is more sensitive to detect pericarditis and pericardial effusion. ECG is always positive in children with pericarditis, so you start with that. But again, it's not diagnostic, but it will increase your suspicion of that. And again, if you suspect it, I think it will be a case to ask a cardiologist to assess, obviously, depending on how easy to get a cardiologist. I know that it might not be quite easy in many places in Sudan.
Another question about reflux. It can cause chest pain, and what is the characteristic of chest pain? قبل كده دكتورة منال الحاج دكتور طارق بيسلم عليك ومرسلك سلام في الشات في مدينة الملك فهد بالرياض، وتوصل لك التحاية.
ايوه، منال زميلتنا واختنا، اشتغلنا معها انا زي ما ذكرت يعني 10 years. كنت في الرياض في مدينة الملك فهد الطبية، فمن هنا أنا برد التحية وأحييها هي وزملائها في طوارئ الأطفال في مدينة الملك فهد الطبية.
شكرا جزيلا. طيب الريفلكس عن chest pain لنا characteristics؟
Obviously, to be honest, because reflux is quite common in infants in our pediatric practice, so they do not present with chest pain as the main thing. They usually present with vomiting, so the painless vomiting, and so infant, even if they experience some chest pain, you will not know whether they are crying because they got chest pain or not. So in an adolescent or somebody with hiatus hernia or other causes, chest pain can present as that. It's not a very common cause of chest pain in children anyway. Reflux is quite common, but chest pain is not a common feature of reflux or gastroesophageal reflux disease also in children and babies. I hope that answers the question, obviously, because I don't have any figures. And probably other colleagues might also contribute to the answer, Kareem or Taha, or you may contribute to the answer if you.
Thank you very much.
asking to talk. معلش تفضل.
Anybody want to talk?
ايوه ياسر وحنان، خلينا ندي فرصه لياسر انه
جدا. اوكي.
ياسر.
السلام
ياسر you
عليكم.
can talk now.
السلام عليكم.
وعليكم السلام.
شكرا دكتور طارق. Thank you Dr. Tariq for very informative presentation and for this very common issue in the year. Actually, I'm working in Prince Sultan Cardiac Center. I'm working as a senior registrar, so I'm facing these cases as I am second on call. They call me for 5 times for the same condition, chest pain. As this is per call, يعني every day I am in duty in service. The first on call he will tell me they are doctors, they call him for the same presentation, يعني chest pain. Here they are very conservative. They are doing a lot of investigation necessary for this children. Actually, chest pain for my work in Prince Sultan for last 7 years or 6 years, I'm facing only 2 patients, but I'm working maybe once per week. I'm talking about my on call only. I find only 2 patients. I refer to the my outpatient clinic. I did for them echo and advanced investigation. 2 of them only they have significant congenital heart disease. Actually, one of them is have subaortic stenosis. And this is same like aortic stenosis that what I mentioned in my comment in the chat. The aortic stenosis is mainly presented with chest pain or collapse or arrhythmia, syncope like that. Another one also presented with hypertrophic cardiomyopathy. And these 2 patients, they are presenting with significant symptom apart from the chest pain. Other symptom may be collapse, arrhythmia, heart failure, like that. Actually, to conclude, but I'm not want to take much time, I will conclude. The Al-Kaaba, what Dr. Tariq mentioned, it presents in 3 to 4 months of age. Actually, they are not presenting with chest pain because at that time, only baby will cry only. And they will present with heart failure and congestive heart failure. This is a major congenital abnormality in the coronary arteries. The other congenital abnormalities that present with chest pain later, this is like intraarterial course of coronary artery, what may present with syncope and other anomalies of coronary arteries, like which in Kawasaki or one he went surgery involves the coronary artery. Chest pain is not uncommon in patients who underwent before cardiac surgery, but usually it will be not significant. He may have chest discomfort or non-specific chest pain like that because of thoracotomy or sternotomy or some tissue adhesions like that. Other things, what we depend on, if you go systematically and you dig in the history by looking for the family history of congenital heart disease, arrhythmia, syncope, sudden cardiac death, all these negative, and the vital sign, mainly the pulse and blood pressure and saturation. If all these negative and your chest X-ray not showing significant cardiomegaly or abnormality in the heart shape, and your ECG is fine, and you don't have clinical finding, I mean like absent or weak pulses, murmur, significant murmur like that. All these with the labs, simple labs, if all these negative, unlikely the patient have cardiac disease. This is from my short experience for 7 or 8 years in the Prince Sultan Cardiac Center in the ER and outpatient. Actually, in the literature, also less than 1% of the chest pain due to the cardiac, unless you have risk factor, a significant risk factor and family history. And Dr. Tariq, Jazawallah Khair, he passed through all the diagnoses and risk factor and approach to the chest pain. And even better than us, we are cardiologists just looking for the ECG and chest X-ray and echo and doing some time advanced imaging like CT or exercise stress test and Holter. Thank you.
Thank you very much, Dr. Yasir. Obviously, I cannot agree anymore with your comment. I think you summarized very nicely what was in this presentation. The studies that I presented show that less than 1% of patients that were studies with HSPN have a cardiac etiology for them. And it's always that they should have other findings, whether on vital signs, on clinical examination, or on ECG that support a cardiac cause for their chest pain. In the absence of this, there is normal clinical examination, negative risk factors, normal ECG, or if you do a chest X-ray, normal X-ray, which are very simple investigations, and cardiac cause is very unlikely. And I think sometimes even for the patients that we see in clinic, we just reassure them, because parents will come very worried that this is a cardiac cause that is causing the chest pain. So once they are get reassured, they can just take simple analgesia and so on. So this presentation, I sometimes can call it is chest pain for the non-cardiologist, obviously. So I mean that my audience, because I always speak this to general pediatrician, to emergency physician, to primary care physician, and so on. I think, and this is the aim is probably just to get an approach, as I mentioned in the objectives, that to describe an approach for pediatric chest pain that will reduce unnecessary resource use while maintaining high quality care. And this is probably more true for conditions like in Sudan, when you don't have all the resources, and even the scarce resources, you want to utilize it to the best for the best interest of the patient, because referring for a cardiologist could mean a lot of a long journey, a lot of money, and things for the parents and for the patients. And so you want to address that. So if you can use an approach that with a high degree of certainty, you can reassure parents, that's good. I know, obviously, because I work in King Fahd Medical City, and probably Manal, if she's still here, she will confirm that. Similar to what you do in Prince Sultan, in other tertiary units in the Middle East or in Europe or in America or so on, they will always get the cardiologist to review this. Also, in the majority of cases, the reassurance could have been done by the primary care physician or by the emergency physician, or in the UK, where we do more of the general pediatrics, because the cardiology referral doesn't go directly from this. It usually goes through the general pediatrics team. So the general pediatric team could confidently reduce. They filter the cases and they show who needs to go for a cardiology assessment. And the rest are reassured and done. And not all the all children need troponin or VQ studies or chest angiogram or all these things. For the LCAP, I think the majority present quite early, because myocardial perfusion will be affected quite well, quite early. But I have actually seen, and that was even I think in Saudi, and one case here, when there is relatively, I don't remember exactly the age, but it was a little bit later presentation. But as you mentioned, although they have chest pain, they will not complain if they are very young. They come with crying, but they come with profuse sweating and heart failure. They usually present with heart failure. I totally agree with you. Thank you for your comment. And I think
معلش
there
دكتور
is somebody else here.
دكتور حنان عندها كومنت، لكن somebody is asking if you put up the protocol, the flow chart في السكرين.
Okay,
And
because
I will allow Dr. Hanan, who you are doing this, allow Dr. Hanan to talk. تفضل دكتور حنان.
yeah.
السلام عليكم ورحمة الله.
وعليكم السلام.
وعليكم السلام.
I am very thankful for Dr. Tarig for this very nice presentation. I am Dr. Hanan, video consultant in MCH in Hail. I work in ER فاي نيد بس some protocol شنو to follow it in the ER because طبعا ER is too busy شنو to manage patient with chest pain because more patient come to شنو to the ER with chest pain. يعني some target يعني point or just physical exam يعني history and physical examination and يعني شنو to do in details to get the cause of chest pain or there is some protocol in Saudi Arabia as general to follow it in the ER. And thank you very much.
Okay, so this is a flow chart which probably summarizes what we have said throughout the presentations, that if somebody presented with chest pain, is there a history of trauma? Obviously, if there is history of trauma, chest X-ray, because there might be rib fracture, maybe lung contusion, maybe muscle contusion, and so on. In the majority, no history of trauma, then you ask about fever and respiratory findings. If there are fever or respiratory finding, again, chest X-ray, consider, I don't know why the showing like that, something, yeah, so consider ECG, echo for myocarditis and pericarditis, or D-dimer CT chest for pulmonary embolism. If there is no, then go to the next page, which is page. Then if there are abnormal cardiac examination, you consider, do a chest X-ray, consider structural abnormality, arrhythmia, myocardial ischemia. If consider for myocardial ischemia, get troponin done. If there is no abnormal cardiac examination, think about gastric cause and explore the gastric causes. If there is no suggestion of gastric cause, if it is reproducible chest pain, it can be costochondritis and or could be psychogenic if there is a stress. So musculoskeletal if there is reproducible chest pain, psychogenic causes stress, and so on, if there is anything to suggest that. Idiopathic needs thorough examination, close follow-up. If everything is normal, this could be pericardial catch syndrome, and that's it.
Thank you very much, Dr. Tarig. It has been very nice and you've been very comprehensive. Lots of nice comments and thanks. الناس بيدعوا عليك يعني في الشات كلهم. وبرضه you are very popular. كومنت من دكتور أبو وسيلة بسلم عليك، دكتور مطيع الحوري. يعني شكلك they are all missing you here يعني. دكتور طارق عبد المطلب برضه they are all sending their greetings. Thank you for your time. We took 1.5 hours, so that's long time. لكن كريم الدين.
طيب, I can't agree more about the importance of this talk. It was elegant presentation, informative, comprehensive, and the choice was good. What is the message of this presentation? There are two messages, in fact. And here I remember the word of Professor Sir Hashim. He used to say, a rare case for you is not rare for a patient. And is not rare for the family. So if the incidence of chest pain due to cardiac causes is less than 1%, that means not to ignore it. We need to work hard. So this is a strong message here. A rare case for you is not rare for the patient. The second message, I think this is a message for our registrar and staff in Sudan. What are the causes of chest pain in Sudan? We have a lot of infection, we have a lot of secular. So this is a good area for you to prepare your thesis and even your research. And secondly, I remember, I forget to tell you that Dr. Tarig was informed in very short time. I informed him only 48 or 72 hours. And he was preparing for traveling. But I know Dr. Tarig, I know his commitment, and he adhered to the commitment despite the short notice to him. Finally, it is a message for all of the attendees. If we appreciate the lecture and the presentation, also we appreciate the attendee and their attendance. And here we invite you, anybody here who is interested to present or to deliver any type of talk, you can communicate with Dr. Taha. Hopefully to see you next week. And also I miss Professor Sati. Professor Sati is there, the mic for you, Professor Sati. Otherwise, we will meet next week, inshallah, on the same time. Thank you very much, Dr. Tarig. I wish you the best. I wish you prosperity. And inshallah, we will meet again.
شكرا جزيلا كريم. أنا will speak now in Arabic. أول حاجة التحية لكل الإخوة اللي أرسلوا لي تحياهم، ودي طبعا يعني فرصة عظيمة رغم أن أنا تركت السعودية تقريبا قبل 9 سنوات، ولكن ما زلت أحمل يعني كثير من الذكريات والطيبة، والإخوة مطيع الحوري وعبد المطلب والجميع اللي تم ذكرهم. حتى أنا قبل ما أعمل البرزنتيشن دي I went through my previous يعني فوتو ألبومز، ووجدت بعض الصور لعملي في جمعية طب الأطفال في الرياض، اللي أنا تشرفت برئاستها لدورة تقريبا 3 سنوات، وعقدنا فيها نشاطات أكاديمية ونشاطات اجتماعية وغيرها. فيعني رغم أنه زي ما قال كريم الدين أنه كانت very short notice، لكن أنا ما كان إلا لو ألبي يعني طلب جمعية الأطفال أو أي تجمع أطفال، يعني رغم أن أنا ما كنت عارفه، لكن يعني حتى قبل ما افكر انا ممكن اقدم شنو او كده، ده قلت لازم يكون في شيء انا ممكن اقدمه يعني كنت سعيد جدا بالدعوه، وسعيد انه البرنامج ده يستمر، وان شاء الله يعني انا اواصل اقدم لكم اكثر. يعني الاخوه في مدينه الملك فهد الطبيه يذكروا يعني شغفي كان بالتعليم، وكنت المسؤول عن الميديكال education في الديبارتمنت، وكنت بعد البرنامج والنشاطات الأسبوعية فيعني هو شغف قديم، وإن شاء الله يعني أتواصل معكم. ورغم زي ما قال الفيري بيزي سكيدول الواحد داخل فيه هنا دي، والحياة القاسية اللي الفيري بيزي يعني في الغرب عموما، لكن ما كان لي أي يعني إلا ألبي طلبكم يعني إن شاء الله. وأشكركم جميعا يعني للحضور وللمشاركة، وأتمنى أنه تكون يعني أسهمت ولو بقدر قليل. يعني أنا كنت لما فكرت في تشيس بين فكرت أنه دي قد ما تكون a hot topic for people in Sudan يعني especially in Sudan يعني. لكن هو طبعا الجروب is quite diverse، يعني الجروب هو ناس في السعودية وفي كده، يعني الوضع عندهم مختلف. من الحاجات الاستاديز دي كلها done في الغرب. there is no mention for rheumatic heart disease. I'm sure rheumatic heart disease with pericarditis, myocarditis, and others is a cause of chest pain, although we didn't mention it here. Thank you.
شكرا جزيلا. well attended by the way, more than 130 attendees يا دكتور طارق، فربنا يجعل من حسناتك ان شاء الله. معنا
الله
دكتور احمد عبد
يسعدك.
الهادي برضه، يعني مطيع بيقول لك معنا احمد عبد الهادي.
نعم ما شاء الله.
احمد عبد
أحمد
الهادي
كلهم.
موجود؟
أحمد عبد الهادي السيد الكدرو ما
يا
شاء
احمد
الله.
عبد الهادي، دكتور احمد عبد الهادي لو موجود ده سمعنا صوتك بالله قبل ما نطلع.
raise your hand and I will let you in.
تحياتي له الكثيرة يعني. يعني كل الأشياء دي تجلب لي كثير من الذكريات السابقة يعني. وشكرا لكم يعني أنكم ذكرتني بأيام جميلة.
ثانك يو فيري ماتش. شكرا جزيلا. الميكروفون معك يا طه.
Nothing to say. Thank you very much for everyone who attended. We hope you all enjoyed or you learned something new. We will see you inshallah next week. I just sent in the chat the link for the YouTube for those who missed the meeting. مرة ثانية دكتور طارق, thank you very much. We يعني very grateful to your time and your great experience that you shared with us. I hope we will see you again in future. Thank you.
إن شاء الله.
ثانك يو
Thank
ثانك
you.
يو.
مع
السلام عليكم.
السلامة.